Transporting students with disabilities will present some new challenges that you will find interesting, confusing, and frustrating, as well as rewarding. You may not feel comfortable or sure of yourself at first. That's to be expected. Gradually, you will become more comfortable as you learn to appreciate the individual children and learn more about their disabilities. Disabilities, like individuals, vary greatly. You can learn some of the characteristics of various disabling conditions, but never forget that the focus should be on the individual student. Students will always be kids first, and then kids with disabilities. As you learn some of the characteristics of disabilities, you will also learn some ways of making sure the bus ride is a positive experience for each child. Some students with disabilities may behave in a way that you don't expect or haven't seen before. Some will use assistive devices like wheelchairs, communication boards, crutches, hearing aids, or computers as a part of their daily lives. Some people with disabilities may have health complications that may become emergencies at times. You may feel that you need to have more information about disabilities and medical conditions to make you feel more comfortable and confident in dealing with the students you will be transporting. You'll be able to explore the different disabilities listed on this DVD to gain insight into a particular student's needs. Once you receive information about any child with special needs, record it and store it in the route book so it's readily available. Asking parents or school staff questions about how a child's disability or medical condition might affect him or her on the bus or in an emergency is not a violation of the child's or family's confidentiality, as long as you do not share this information with others. In this section, you have the opportunity to learn about some of the typical disabilities you'll encounter as a school bus driver. Use this resource to learn about a particular disability or illness. It includes a description of the disability or illness, typical behaviors that could occur on the bus, and how you should handle these situations. Allergy, also known as hypersensitivity, is an altered immune response to a usually otherwise harmless substance. Children with allergies have increased sensitivity to one or more substances that ordinarily would be harmless in most people. Those affected by this sensitivity develop allergic responses when the substance is taken into the body through the nose, lungs, mouth, or skin. An allergic reaction can occur in almost any part of the body, and the location of the reaction determines the symptoms produced. In the nose, symptoms include nasal itching, sneezing, stuffiness, and a runny nose. In the eye, symptoms include itching, tearing, redness, and swelling. In the bronchial tubes within the lungs, asthmatic symptoms such as cough, wheezing, and difficulty breathing occur. In the skin, symptoms include rashes such as hives and eczema. In the digestive tract, vomiting, abdominal pain, and diarrhea may occur. Allergic reactions that occur in the nose, eyes, and bronchial tubes are usually caused by airborne allergens such as pollens, dust mites, molds, and animal dander. Allergic reactions that involve the skin and digestive tract are more often caused by foods. However, in some instances, rashes can be caused by airborne allergens, and sudden episodes of wheezing can be triggered by foods. At the start of every school year, check your student list to find out if any child on your bus has allergies. In some cases, the driver or branch staff may make introductory calls to parents. This is a good opportunity to ask questions regarding a child's health. If you notice one of the children having an allergic attack on your bus, radio dispatch and let the school staff know who's having the problem so they can help the child when you get to school. If the child is having an attack on the way home, make sure when you drop the child off that an adult is aware of the problem. Arthritis, which literally means inflammation of a joint where two or more bones meet, actually refers to more than 100 different diseases. Rheumatic diseases include any disease that causes pain, stiffness, and swelling in joints or other supportive body structures, such as muscles, tendons, ligaments, and bones. Arthritis affects over 285,000 children in the United States annually. Each child may experience symptoms differently, and different types of rheumatic diseases present different symptoms. In general, however, symptoms may include joint pain, swelling in one or more joints, joint stiffness that lasts for at least 1 hour in the early morning, chronic pain or tenderness in the joints, warmth and redness in the joint area, limited movement in the affected joints, fatigue, and/or persistent fevers. A child living with a rheumatic disease doesn't necessarily have to live a limited lifestyle. Living with chronic pain and fatigue may leave the child feeling depressed and less able to cope with the pain. A cycle of pain, depression, and stress may keep a child from living his or her life to the fullest. As his or her bus driver, get to know the child and ask how he or she is feeling when you sense something may be wrong. Ask in private though, since most children don't want to be stigmatized as being different. Asthma is a chronic inflammatory disease of the airwaves. About 5 million children have asthma. It's been on the rise over the last 15 years, and we don't know why. Some theories include environmental exposures and genetics. It affects more males than females in childhood, and then around adolescence, these trends reverse. African Americans are disproportionately affected more than whites or other non-whites, especially those living in the inner cities. About 80% of asthmatic children are also allergic. The most common allergens include pollens from weeds, grasses, and trees, molds, dust mites, cockroaches, and pets. Symptoms vary in children, but most commonly include one or more of the following: cough, wheeze, chest tightness, or shortness of breath. Know which children on your bus have asthma. If a child you know has asthma and is coughing a lot, report it to the school staff because they should have the appropriate medications to give the child relief. If the child is allowed to carry an inhaler, make sure you know about it. Instruct the child to always tell an adult if he or she is having trouble. Encourage kids on your bus with asthma to let you know if they're having trouble breathing so that you can radio dispatch to alert the school staff. Attention Deficit Disorder, or ADD, and Attention Deficit Hyperactivity Disorder, or ADHD, are conditions that interfere with the student's ability to pay attention or focus for any amount of time on a task. ADHD makes it hard for its victim to sit still, control behavior, and pay attention. Symptoms in children with ADD or ADHD include impulsive, hyperactive, and distractible behaviors beyond what is considered normal for their age. You may notice the child fidgets, can't remain seated, has difficulty waiting in line for the bus, blurts out answers to questions before you have even finished the question, has difficulty following instructions, loses things, and has difficulty listening to others without being distracted. Students with ADD do want to control their behavior, but they need your help to do it. Some things you can do to make your bus ride more pleasant for you and the student are: make rules and expectations clear. Catch the student doing something well and praise him or her for it. Say his or her name and establish eye contact. Determine which behaviors you can ignore as long as they are not unsafe behaviors. Give directions one at a time. Consider whether you can give students time out by having them sit alone. Use a secret signal with the student as a reminder that he or she is misbehaving. This way, the student isn't embarrassed in front of his peers. Anticipate and plan for times when students will have more difficulty, for instance, when routines change before holidays or vacations. While there is no quick treatment for this disorder, the symptoms can be managed. Have high expectations for the student, but be willing to try new ways of doing things. Be patient and maximize the student's chances for success. Autism is a developmental disability that is the result of a neurological disorder that affects brain function. Autism is 4 times more prevalent in boys than girls. Autism knows no racial, ethnic, or social boundaries, and family income, lifestyle, and educational levels do not affect the chance of autism's occurrence. Autistic children typically have deficiencies in verbal and nonverbal skills and social interactions. The disorder makes it hard for the child to communicate with others and relate to the outside world. They may exhibit repeated body movements, like hand flapping or rocking back and forth. They also show unusual responses to people. They become very attached to certain objects and may resist any change in routine. In rare cases, they may be aggressive to themselves or to others. In order to make the bus ride enjoyable for an autistic child, first try to learn all you can about him or her. Find out what kind of things upset the child and the best way to manage their behavior. Try to keep the bus routine consistent. Find ways of showing the child affection without touching him or her. Don't be hurt by a lack of emotion from the child. Ignore the rocking or flapping as long as it is not disruptive to other students. Try to learn about the child, to learn how he or she communicates. Tell him or her what to do rather than asking yes or no questions. Supervise the boarding of the bus and direct the child to sit down. You may need to speak with the individual education plan or IEP team about using a seat belt to help keep an autistic child in their seat. There are many myths and misconceptions about autism. Contrary to popular belief, many autistic children do make eye contact. It just may be less or different from a non-autistic child. Many children with autism can develop good functional language, and others can develop some type of communication skills, such as sign language or use of pictures. Children do not outgrow autism, but symptoms may lessen as the child develops and receives treatment. One of the most devastating myths about autistic children is that they can't show affection. While sensory stimulation is processed differently in some children with autism, they can and do give affection. But it may require patience on your part to accept and show acceptance in the child's terms. Cerebral palsy is a medical condition caused by a permanent brain injury that occurs before, during, or shortly after birth. Cerebral palsy, or CP, is characterized by lack of muscle control and body movement. While it is not a progressive disease of the brain, the effects of cerebral palsy may change gradually over the years. CP can be mild, moderate, or severe. Mild CP may mean a child is clumsy and may need some help getting on and off the bus. Moderate CP may mean the child walks with a limp. He or she may need a special leg brace or a cane. More severe CP can affect all parts of a child's physical abilities. A child with severe CP may have to use a wheelchair and other special equipment. There are different types of cerebral palsy. Spastic is characterized by stiff, permanently contracted muscles. Muscle tone is increased in one or many limbs. Athetoid or dyskinetic is characterized by involuntary, uncontrolled movement of arms, hands, legs, or feet. Severe cases may affect the muscles of the face, mouth, or tongue. Ataxic is characterized by problems with balance and depth perception, unsteady gait, poor coordination, and poor motor control are common. Mixed type is 2 or more types of cerebral palsy occurring in one patient. A child with CP can face many challenges in school and is likely to need individualized help. Children with CP may need assistive technology to help them communicate. They might have a communication board with pictures, symbols, letters, or words attached. Some children may have electronic means of communicating with either a toy with special switches or even a computer operated by simple switch pads or keyboard adaptations. Be available to steady students while walking, if asked to do so. If you have concerns about the student's balance ability to sit comfortably while riding the bus, speak with the parents, teacher, or school administrator about ways to remedy the situation. Be aware of where arms and legs are when going through doorways or tight spaces. If a trimmer knocks a foot off the foot pedal of the wheelchair, gently lift the foot back onto the pedal. Some students may need a Y or V harness for stability. Be patient with a CP child. You may have to ask them to repeat what they've just said to you, as his or her speech may be impaired. Move slowly and do not startle the child. Fast movements or loud noises make them jump and can make them stiffer or floppier than usual. Another behavior some of these students can't help is nervous laughter. Some may laugh when you bang your head, and the laughter can be irritating. Keep in mind that it is not intentional, but an uncontrolled reaction. You might try to tell the student that you know he can't help it, but it hurts your feelings when he laughs if you hurt yourself. Effective teamwork for the child with CP needs to bring together you, the parents, and school administrators. Everyone should combine his or her knowledge to plan, implement, and coordinate what is best for the child. Some things you can do to make your bus ride more pleasant for you and the student are: make rules and expectations clear. Catch the student doing something well and praise him or her for it. Say his or her name and establish eye contact. Determine which behaviors you can ignore as long as they are not unsafe behaviors. Give directions one at a time. Consider whether you can give students time out by having them sit alone. Use a secret signal with the student as a reminder that he or she is misbehaving. This way, the student isn't embarrassed in front of his or her peers. Anticipate and plan for times when students will have more difficulty, for instance, when routines change before holidays or vacations. Cystic fibrosis is a genetic disease affecting approximately 30,000 children and adults in North America. CF causes the body to produce abnormally thick, sticky mucus within cells lining organs and their outer surfaces, such as the lungs and pancreas. The thick CF mucus also obstructs the pancreas, preventing enzymes from reaching the intestines to help break down and digest food. Kids with CF may get chest physical therapy, where someone thumps on their chest after a breathing treatment to help loosen the mucus in the lungs. They also may need to cough a lot during the day to clear out their lungs. Sometimes they may need to eat special foods or follow special diets. Most kids and teens with CF even take pills that help their bodies digest foods and vitamins and also get them the right nourishment. They also take antibiotics whenever needed to help get rid of lung infections or sometimes to prevent an increase of infection. Because CF produces thick mucus within the respiratory tract, a child with CF may suffer from nasal congestion, sinus problems, wheezing, and asthma-like symptoms. As CF symptoms progress, the child may develop a chronic cough that produces globs of thick, heavy, discolored mucus. They may also suffer from repeated lung infections. As chronic infections reduce lung function, the person's ability to breathe often decreases. A person with CF may eventually feel short of breath, even at rest. Despite aggressive medical therapy, lung disease develops in nearly all patients with CF and is a common cause of disability and shortened lifespan. Don't be alarmed if a child on your bus with CF starts to cough. Kids with CF often have coughs that just don't seem to go away. CF is not contagious, so you or the other children on the bus won't catch it. Remain calm if the child has a coughing attack. You may want to privately let the teacher know about it when you get to school. Diabetes is a condition that occurs when there is not enough insulin produced by the body. Insulin is a hormone that allows cells to utilize the glucose or sugar in the blood, creating energy for the body's needs. Body cells need to have glucose to provide the energy we need to live. Cells use glucose from all of the food we eat. When glucose cannot be used for energy, it builds up in the bloodstream. Then, the kidneys filter it out into the urine, and in the process, the body uses a lot of water, thus causing increased thirst. Hunger is another symptom of diabetes caused by the body losing calories as a result of its inability to utilize the glucose from food. When the body can't use glucose, it uses its own fat and muscle tissue for energy. Children and adults with diabetes must control their insulin, either by diet or injections. It's also important for them to exercise regularly and to eat the right amount of food at the right times to balance with the insulin. About 1 in 300 to 600 children under the age of 21 develop type 1 diabetes. Type 1 diabetes may be an autoimmune condition. The triggers are unknown, but the body attacks itself in response to an invader and in turn attacks the beta cells that produce insulin. There are no proven methods to prevent or delay type 1 diabetes. Children with type 1 diabetes need to take injections of insulin. Type 2 diabetes is more commonly known as adult onset diabetes because it mainly occurs in middle-aged or older adults who are overweight. There's usually an excess of insulin produced at first, and the cells are resistant in using all that insulin. Medication, diet, and exercise can be used to manage a person with type 2 diabetes who produces enough insulin. Eventually, the pancreas may not be able to make enough or be effective enough for the overweight body, and insulin injections are required. If a diabetic child becomes hypoglycemic on your bus, his or her blood glucose should be tested right away. Symptoms include shakiness, sweating, irritability, paleness, weakness, stomachache, blurred vision, numbness of the lips and tongue, and headache. If untreated, symptoms may progress to slurred speech, erratic behavior, unconsciousness, and convulsion. In case of an emergency, a diabetic child should always carry a supply of glucose. In the case of severe low blood glucose and eating or drinking is not possible, call dispatch to have them call 911 to send someone immediately to treat for severe hypoglycemia. If a student has a seizure, protect his or her head from injury. Put padding under their head if he or she is on the floor and maintain an open airway. Try to get him or her on their side. If the child is sitting in a seat, sit beside them and protect his or her head. The definition of hyperglycemia is high glucose. When not enough insulin is given, the result is hyperglycemia. Symptoms include headache, nausea, and mild malaise. Additionally, the child's behavior may change and become hyperactive or defiant. Immediate treatment for hyperglycemia is usually not warranted unless the child feels ill or thirsty. Radio dispatch and have them advise school staff. Treatment should be addressed in the student's Individualized School Healthcare Plan, or ISHP. School personnel, in accordance with state law, will administer insulin if needed. Always act in a calm manner in front of the child in order to maintain a relaxed atmosphere for everyone on your bus. Approximately 4,000 children are born with Down syndrome each year. It's caused by a chromosomal abnormality for some reason, an accident in cell development of the body and brain. Children with Down syndrome frequently have specific health-related problems due to a lowered resistance to infection that makes these children more prone to respiratory problems. They also tend to have visual problems, such as crossed eyes and far or nearsightedness. Because of the range of ability in children with Down syndrome, it's important for families and all members of the school's education team to place few limitations on potential capabilities. Teaching tasks in a step-by-step manner with frequent reinforcement and consistent feedback has been proven successful. Some things you can do to make your bus ride more pleasant for you and the student are: make rules and expectations clear. Catch the student doing something well and praise him or her for it. Say his or her name and establish eye contact. Determine which behaviors you can ignore as long as they are not unsafe behaviors. Give directions one at a time. Consider whether you can give students time out by having them sit alone. Use a secret signal with the student as a reminder that he or she is misbehaving. This way, the student isn't embarrassed in front of his or her peers. Anticipate and plan for times when students will have more difficulty, for instance, when routines change before holidays and vacations. Every child faces emotional difficulties from time to time, as do adults. Feelings of sadness or loss and extremes of emotions are part of growing up. Conflicts between parents and children are also inevitable as children struggle from the terrible twos through adolescence to develop their own identities. These are normal changes in behavior due to growth and development. Such problems can be more common in times of change for the family: the death of a grandparent or family member, a new baby, a move to the city. Generally, these kinds of problems tend to fade on their own or with limited visits to a counselor or other mental health professional as children adjust to the changes in their lives. At times, however, some children may develop inappropriate emotional and behavioral responses to situations in their lives that persist over time. This is called emotional behavior disorder, or EBD. There are 3 criteria to help in deciding whether a child's behavior is normal or a sign that a child has EBD. First, the duration of a troublesome behavior. Does it just go on and on with no sign that the child is going to outgrow it and progress to a new stage? The intensity of a behavior. For instance, while temper tantrums are normal in almost all children, some tantrums could be so extreme that they are frightening to parents and suggest that some specific intervention might be necessary. Parents should pay a particular attention to a behavior, such as feelings of despair or hopelessness, lack of interest in family, friends, school, or other activities once considered enjoyable, or behaviors which are dangerous to the child or to others. The age of the child. While some behavior might be quite normal for a child of 2, observation of other children of the youngster's age may lead to the conclusion that the behavior in question is not quite right for a 5-year-old. Not all children reach the same emotional milestones at the same age, but extreme deviations from age-appropriate behaviors may well be cause for concern. As a bus driver, you'll have to notice the events on the bus ride that'll help maintain good behavior. This may mean letting the child sit by themselves. Use and consider many different techniques while trying to correct any disruptive behavior. Get advice from teachers and parents as to how to manage the EBD child on the bus. Some things you can do to make your bus ride more pleasant for you and the student are: make rules and expectations clear. Catch the student doing something well and praise him or her for it. Say his or her name and establish eye contact. Determine which behaviors you can ignore as long as they are not unsafe behaviors. Give directions one at a time. Consider whether you can give students time out by having them sit alone. Use a secret signal with the student as a reminder that he or she is misbehaving. This way, the student isn't embarrassed in front of his or her peers. Anticipate and plan for times when students will have more difficulty, for instance, when routines change before holidays or vacations. Remember, never give up hope. By talking to his or her teachers and parents, you'll gain better insight to deal with a child with EBD. Epilepsy is a nervous system disorder that produces sudden, intense bursts of electrical activity in the brain. This abnormal electrical activity in the brain causes seizures, which may briefly upset a person's muscle control, movement, speech, vision, or awareness. People with epilepsy have repeated seizures that usually occur without warning and often for no clear reason. If epilepsy is not treated, seizures may occur throughout a person's life and in some cases become more severe and more frequent over time. Treatment most often involves medication. There are two basic types of seizures caused by epilepsy. Generalized seizures begin over the entire surface of the brain and may affect the entire body. In people who have generalized seizures, it's impossible to pinpoint a specific location in the brain that's the source of the seizure. Partial seizures begin in a specific location in the brain. Partial seizures may affect awareness on only one side or part of the body, but they may also generalize to affect the entire body. Epilepsy is not a form of mental retardation or mental illness. Although a few forms of childhood epilepsy are associated with below average intelligence and problems with physical and mental development, epilepsy does not cause these problems. Seizures may look scary or strange, but they don't make a child violent or dangerous. Seizures usually do not harm the person who has them, but they can be dangerous. A seizure can happen anytime, anywhere, and there is always a risk of head injury, broken bones, and other injuries from falling. If the child has a seizure while swimming or bathing, he or she could drown. Children do not swallow their tongues during seizures, but they may choke on food, vomit, or any object that they may have in their mouths. If a child has a seizure on your bus, try to protect him or her from injury. Keep the child from falling if you can. Try to turn the child on his or her side with his or her mouth down unless they resist being moved. Don't try to hold the child down. After a seizure, check the child for injuries. If you are unable to turn the child on their side during the seizure, do so now while he or she is more relaxed. If the child is having trouble breathing, put on a latex glove and gently clear their mouth of any vomit or saliva. Provide a safe area where the child can rest. Never put anything in their mouth. Stay with the child until he or she is awake and familiar with the surroundings. He or she may fall asleep. A person who just had a seizure is often confused for a short time after the seizure. In the event of a seizure, radio dispatch. Dispatch will communicate with EMS, authorities, school administrators, or parents to decide the best course of action for the child. Fetal alcohol syndrome is a lifelong set of physical, mental, and neurobehavioral birth defects associated with alcohol consumption during pregnancy. Children with FAS have a distinct pattern of facial abnormalities, growth deficiency, and evidence of central nervous system dysfunction. In addition to mental retardation, individuals with FAS may have other neurological deficits, such as poor motor skills and hand-eye coordination. They may also have a complex pattern of behavioral and learning problems, including difficulties with memory, attention, and judgment. Keys to working successfully with FAS children are structure, consistency, variety, brevity, and persistence. Because these children can lack internal structure, caretakers, teachers, and you need to provide external structure for the child. It's important to be consistent in response and routine so that the child feels the world is predictable. Because of serious problems maintaining attention, it's important to be brief in explanations and directions, but also to use a variety of ways to get and keep their attention. Finally, you must repeat what it is we want them to learn over and over again. Many FAS children have difficulty structuring work time, show impaired rates of learning, experience poor memory, have trouble generalizing behaviors and information, act impulsively, exhibit reduced attention spans or are distractible, display fearlessness and are unresponsive to verbal cautions, demonstrate poor social judgment, have trouble internalizing modeled behaviors, may have differences in sensory awareness such as hyposensitivity or hypersensitivity, have language production higher than comprehension, and show poor problem-solving strategies. Effective strategies include fostering independence in self-help and in play. Give the child choices and encourage decision-making. Establish a few simple rules. Use identical language to remind them of the rules. This is your seat. This is where you're supposed to sit. Establish and keep routines so the child can predict coming events. Give the child lots of advance warning that activity will soon change to another one. If you have to discipline a FAS child, set limits and follow them consistently. Review and repeat consequences of behaviors. Ask them to tell you consequences. Don't debate or argue over rules already established. Notice and comment when the child is doing well or behaving appropriately. Avoid threats and redirect behavior, if needed. Intervene before behavior escalates. Avoid situations on the bus where the child will be overstimulated. Have the child repeat back to you their understanding of the rules. These kids have a complex pattern of behavioral and learning problems, so be patient with them. Symptoms of Fragile X include mental impairment ranging from learning disabilities to mental retardation, attention deficit and hyperactivity, anxiety and unstable mood, autistic-like behaviors, long face, large ears, flat feet, and hyperextensible joints, especially fingers, and seizures, which affect about 25% of people with Fragile X. Boys are typically more severely affected than girls. While most boys with Fragile X have mental retardation, only 1/3 to 1/2 of girls with Fragile X have significant intellectual impairment. The rest have either normal IQ or learning disabilities. Emotional and behavioral problems are common in both sexes. Patients as young as 2 or 3 years have been noted to exhibit the following physical findings: long and/or wide and/or protruding ears, prominent jaw or long face, high arched palate, flattened nasal bridge, creases of the palms or vertical creases of the soles of the feet, long hyperextensible joints, and prominent forehead. Some things you can do to make your bus ride more pleasant for you and the student are: make rules and expectations clear. Catch the student doing something well and praise him or her for it. Say his or her name and establish eye contact. Determine which behaviors you can ignore as long as they are not unsafe behaviors. Give directions one at a time. Consider whether you can give students time out by having them sit alone. Use a secret signal with the student as a reminder that he or she is misbehaving. This way, the student isn't embarrassed in front of his or her peers. Anticipate and plan for times when students will have more difficulty, for instance, when routines change before holidays or vacations. Health impaired means limited strength, vitality, or alertness due to chronic or acute health problems, including heart conditions, asthma, diabetes, kidney disease, serious allergic reactions, and heart, lung, or cancer conditions that adversely affect a child's educational performance. The child's teachers, school staff, or parents will inform you of the child's condition. You should find out what the condition is, what the symptoms are, what can happen, what can trigger a reaction, how to prevent a reaction, and what should be done. Record and store this information in the route book so it is readily available when needed. If there's something out of the ordinary that has happened on the route, report any information to the school. This may determine if the child needs further medical assistance. Human immunodeficiency virus, or HIV, is the virus that causes AIDS. The virus infects a type of white blood cell which alters the body's immune system's ability to function adequately. A person infected with HIV may not have any symptoms for months or years, but in children infected by their mothers, signs of AIDS may be present within months after their birth. HIV is transmitted from person to person through intimate sexual contact, sharing contaminated needles, infected mothers passing the infection to their children during the birth process, and, prior to 1985, through infected blood products. Some of the children on your bus might have been born with HIV. They may not grow normally and may be lethargic at times. Students with AIDS may miss a lot of school because of ill health. Keep in mind that AIDS is not spread by routine casual contact, so you can react calmly and rationally when helping students who may have AIDS. You don't have to do anything differently when you're dealing with a child with AIDS. If you're going to be exposed to blood or bodily fluids, wear gloves to protect yourself. Every child infected with and affected by HIV/AIDS deserves compassion and support, regardless of the circumstances surrounding their infection. Education is crucial to getting this message out. Hearing loss varies greatly. Some children may only have mild losses, while others can't hear at all. Some of the children will have permanent losses, and others will have losses that are corrective with treatment or through the use of amplification aids. Some students have been deaf since birth. Others lost their hearing because of an injury or illness after they learned to speak. The level of intelligence, the degree of hearing loss, and the age at which the loss occurred determines how well hearing-impaired children function. In many cases, if hearing losses are severe and if they occurred at an early age, hearing-impaired children may have severe discrepancies in speech and language. Consequently, you may have difficulty in communicating with some students with hearing impairments. Students with hearing impairments may have speech and language problems that affect their ability to learn without various forms of communication being used. You need to know which forms of communication are being taught and what you should use on the bus. While on the bus, the children may talk loudly or make loud noises because they can't hear themselves. Like all children, they may become upset and kick, bite, hit, or throw objects. Some may touch or poke other children to get attention. When attempting to communicate, face the hearing-impaired child directly and make eye contact. Speak slowly in a normal tone of voice. Many can lip read. Visit with teachers and learn what communication methods are being taught to the child and how you can use the same methods on the bus. If possible, Place students where they can see your face in the rearview mirror. Use facial gestures to get your message across to them. Have specific rules and enforce them fairly, firmly, and consistently. Enforce one specific rule that all passengers remain quiet while you are communicating with the hearing impaired student. Use appropriate communication methods for each hearing impaired student. You may be able to use speech, or you may have to write something down for the child to read. The best thing to do is learn from the IEP team their communication suggestions for the child. You may want to learn a few words in sign language too. Use all your resources to communicate information as well as to have a positive relationship with the hearing impaired child. Students with learning disabilities exhibit a wide range of characteristics. These include problems in reading, writing, speaking, listening, reasoning, or memory. Problems with attention, organization, coordination, and social skills are also frequently associated with learning disabilities. When a student has a learning disability, it means that he or she learns differently than most students, and the learning is more difficult than it is for most other students. A basic characteristic of students with learning disabilities is a significant difference between a student's actual achievement and performance in some areas and his or her overall potential for learning. Students with learning disabilities have average or above average intelligence, but have significant difficulty in learning basic skills. No two students with learning disabilities will be alike or have the same behaviors. Each student has a different learning style, pace, and capacity. It's best to get to know the students as individuals, determine their interests and abilities in areas that they need assistance. Some general signals that might indicate learning difficulties of a child on your bus include difficulty understanding and following instructions on the bus, trouble remembering what you or another student just told him or her, difficulty distinguishing right from left, up from down, over from under, etc. Communicate with parents and teachers to understand the nature of learning disabilities and how they affect the student's behavior on the bus. Make sure you have the child's attention before giving directions. Have 5 or 6 rules stated simply in writing, as well as telling students verbally. Be patient. You may have to repeat the rules daily or even several times a day. Give instructions in short sentences, 1 or 2 steps at a time. Talk slower in simpler sentences with simple vocabulary to make your point clear. Encourage students to request help when it's needed. Remain calm and consistently neutral. Students will react to impatience, anger, or disapproval. If you must correct a student, do it with a short, brief description on what was wrong and what they need to do instead. If at all possible, wait until you can speak privately with the student. Focus on the behavior. Say the student's name. Wait until you have the student's attention. Say as quietly and calmly, "Please sit down in your seat." Speak with your supervisor, who may refer you to parents, teachers, or a consultant in the area of learning disabilities. They can help you with strategies to use if you're having trouble getting through to the child, or just as another person to seek advice about learning disabilities. Children who are medically fragile may have complex health needs, multiple health needs, or are dependent on medical technology. Children who require continuous, ongoing specialized healthcare procedures include, but are not limited to, mechanical ventilation, continuous administration of oxygen, continuous cardiopulmonary monitoring, and a combination of procedures such as tracheostomy care and suctioning and gastrostomy feedings. Children who require an intermittent specialized healthcare procedure or procedures, but are not limited to, nasal, gastric, or gastrostomy feedings, tracheostomy care, medications via injection, inhalation, or complex regimens, Children with identified conditions of unusual severity who require specialized services occasionally due to potential for occurrence of a medical crisis but are not limited to uncontrolled seizure disorder, unstable diabetes, severe immune deficiency, and poorly controlled asthma. In the past, children were often labeled as mentally retarded or mentally disabled based on a low IQ score. Now, we know that the IQ scores don't really tell us much about how a student gets along at home, in the community, or at school. An IQ score doesn't always tell us what a student's potential is, nor what specific supports each student needs to do well in his or her environment. Students with mental disabilities vary greatly in personality and ability. They have difficulties in adaptive skill areas like social interactions and self-direction. But the nature and type of difficulties vary from individual and from time to time for each individual. Therefore, it's important to approach each student as an individual and determine each student's strengths and areas that he or she might need support. Ask the student, parents, and teacher what type of support you can offer to assure a safe bus ride. Try to establish and maintain a routine so students can learn the routine. Tell students the bus rules. Demonstrate how to follow the rules. One example is how to board the bus by holding on to the handrail. Remind the students of the rules. Tell them, remember to stay in your seats when the bus is moving. If you know of a change in the bus routine, tell the students ahead of time. Remember that changes may make some students more uncomfortable than others, and they'll need more support from you during changes. Stay calm and consistent. Students need to be able to rely on you to be in control, to be fair, and to enforce and follow the rules at all times. Ask for input from the school about how each student should be evacuated from the bus in case of an emergency. Remember to keep in close contact with the student's teacher and parents. They are always there as a support group for any questions or concerns you may have about the child. Muscular dystrophy, or MD, refers to a group of genetic diseases characterized by progressive weakness and degeneration of the skeletal or voluntary muscles which control movement. The muscles of the heart and some other involuntary muscles are also affected in some forms of MD, and a few forms involve other organs as well. MD can affect people of all ages, although some forms first become apparent in infancy or childhood. Others may not appear until middle age or later. There's no specific treatment for any of the forms of MD. Physical therapy helps prevent a condition in which shortened muscles around joints cause abnormal and sometimes painful positioning of the joints. Orthopedic appliances used for support and corrective orthopedic surgery may be needed to improve the quality of life in some cases. The cardiac problems that occur with MD may require a pacemaker. The prognosis of MD varies according to the type of MD and the progression of the disorder. Some cases may be mild and very slowly progressive, with normal lifespan, while other cases may have more marked progression of muscle weakness and functional disability. When they are little, kids with muscular dystrophy don't look any different from other kids. Later on, though, you might be able to tell that someone has MD because he or she may have trouble walking. He or she might use a wheelchair or leg braces to help them move around. The weakness that kids with MD feel is a muscle tiredness that's always there. It's there when they wake up and when they go to sleep. Because of this weakness, they may have trouble getting up from the bus seat, playing some sports, or running on the playground at recess. Kids with muscular dystrophy may use canes and leg braces to help them walk. They may use wheelchairs when their muscles get weaker. Some kids have specially trained dogs to open doors for them and carry small objects like books or toys. Children with muscular dystrophy also want to be treated like other kids. Help when they need it, but remember, don't hover. Multiple sclerosis is a chronic, often disabling disease that attacks the central nervous system. Symptoms may be mild, such as numbness in the limbs, or severe, such as paralysis or loss of vision. The progress, severity, and specific symptoms of MS in any one person cannot be predicted. MS is very rare in children. Symptoms usually strike between the ages of 20 and 40. MS is not a fatal disease. Individuals with MS have near normal life expectancies. Most people with MS learn to cope with the disease and live full, productive lives. The symptoms of MS may include tingling, numbness, painful sensations, slurred speech, and blurred or double vision. Some children experience muscle weakness, poor balance, poor coordination, muscle tightness, or spasticity, or paralysis that may be temporary or permanent. Problems with bladder and bowel function are common. Fatigue is a major concern for many. MS can cause forgetfulness or difficulty concentrating. It can also cause mood swings and may make children more susceptible to depression. Because MS affects individuals so differently, it's difficult to make generalizations about the disability. Statistics suggest that 2 out of 3 people with MS remain able to walk over their lifetime, but many of them will need a cane. Some will choose to use a scooter or wheelchair to conserve energy. Others will require a wheelchair to maintain mobility. The symptoms of MS can affect every aspect of a child's daily life. Ask them if they need help boarding or getting off the bus, but don't embarrass them in front of their peers. Keep in contact with the parents, teachers, and school administrators to monitor how to best work with a child or teen who has MS. Students may be born with or acquire problems with their bones, joints, and/or their muscles. Orthopedic problems may result from deformities, diseases, injuries, or surgeries. Injuries or surgeries may result in the loss of a bone and/or muscle tissue and may include the amputation of a limb. Burns and broken bones can also result in damage to both bones and muscles. The result of orthopedic problems varies, but generally students may have problems using legs, arms, and hands, or moving in a manner you're accustomed to watching. Some will use assistive devices to help them function as independently as possible. As a group, they vary greatly in mental ability. Some will have average or above average intelligence. Some may have below average ability. Some with cerebral palsy may not be able to communicate in traditional ways. Some may need assistance from you or from others in getting on the bus and while on the bus. Physical limitations range from very mild to very severe. Personalities vary as greatly as in any group of students. Physical abilities may vary greatly. Some may be more prone to seizures than other students. Some often have other limitations, such as sensory problems or memory problems. Some are on medication. Some may be used to having things done for them and may need your encouragement to try things on their own. Allow them as much freedom and time as safely possible to get on and off the bus, to secure themselves, and to meet other requirements. Personally see that all seat belts are secured, wheelchairs are locked in place, and other devices are secure before moving the bus. Make sure that rules are understood. Enforce rules fairly, firmly, and consistently. Resist the temptation to feel sorry for these children. If you don't know or aren't sure, ask the parents, the classroom teacher, or therapists for advice. Develop a specific plan for each passenger in case of emergencies, need for evacuation, seizures, behaviors, or other types of problems. Do this with input from the IEP team, which includes parents, teachers, therapists, and school administrators who should help decide the safest way to handle emergency situations. Spina bifida is caused by a malformation or incomplete formation of the spinal cord that happens before birth. Spinal cord injuries are usually caused by traumatic injuries to the spinal cord, resulting from car accidents, motorcycle and bicycle accidents, gunshots, or falls. Both spina bifida and spinal cord injuries result in partial or complete paralysis of the muscles of the trunk or legs. Students with spina bifida may also have an enlarged head. Those students may also experience learning problems. Some children will need crutches, braces, or wheelchairs, with or without adaptations for posture or correct positioning. They may also wear helmets. These children may not feel pain or heat in affected areas, such as the legs, hips, or buttocks. Report any bumps, bruises, cuts, or burns that occur in transit. These heal very slowly due to poor circulation in the affected areas. Since they do not feel heat or cold, be careful where you place the children. Keep them away from heat registers and cold metal or even drafts. Students with shunts that are malfunctioning may begin vomiting. Radio dispatch anytime this happens. Children with spina bifida have a lifelong allergy to latex, so you'll have to use non-latex gloves if you have to clean up the vomit while the child is still on the bus. If there is an emergency, make sure you let the paramedics know that they should not wear latex gloves either. This is important. Take care to see that the shoulder harness of the safety belt does not put pressure on a shunt. Some younger children may have poor bowel or bladder control and may wear diapers. Some older children may use a urine collection bag that should be emptied at home and at school. However, if you smell urine or feces on students, report it to the school staff or the students' parents. Some children may be able to walk, but just might have balance problems. Keep your eye out for them and be sure to be there, ready to lend an arm for support. A student with spinal cord injuries may be grieving the losses he or she suffered as a result of an accident. They may be emotional and irritable or angry as they learn to cope with the changes in their life. His or her grieving might be more intense at times. Be patient with them. It's important that all members of the school team and the parents understand any physical capabilities and limitations of a child with spina bifida or spinal cord injuries. Communicate regularly with the school and the parents on the needs of your passenger. Tourette syndrome, or TS, is an inherited neurological disorder characterized by repeated involuntary movements and uncontrollable vocal sounds called tics. In a few cases, such tics can include inappropriate words and phrases. The symptoms of TS generally appear before the individual is 18 years old. Although TS symptoms range from very mild to quite severe, the majority of cases fall into the mild category. The first symptoms of TS are usually facial tics, commonly eye blinking. With time, other motor tics may appear, such as head jerking, neck stretching, foot stamping, or body twisting and bending. It's not uncommon for a person with TS to continuously clear his or her throat, cough, sniff, grunt, yelp, bark, or shout. A person with TS may touch other people excessively or repeat actions obsessively and unnecessarily. A few patients with TS demonstrate self-harming behaviors, such as lip and cheek biting, and head banging. People with TS can sometimes suppress their tics for a short time, but eventually tension mounts to the point where the tic escapes. Tics worsen in stressful situations and improve when the person relaxes or is absorbed in an activity. The majority of people with TS require no medication, but medication is available to help with symptoms interfering with functioning. TS medications are only able to help reduce specific symptoms. Relaxation techniques and biofeedback may be useful in alleviating stress. There's no cure for TS. However, the condition in many individuals improves as they mature. Individuals with TS can expect to live a normal lifespan. Although TS is generally lifelong and chronic, it's not degenerative. In a few cases, complete remission occurs after adolescence. As always, keep in contact with the parents and the school administrators as to how the child is doing and if there's anything you can do to make the child's bus ride more enjoyable. Most often, normal vision is measured in a doctor's office as a visual acuity of 20/20. A person with a visual impairment has an eye problem that leaves the person with less than 20/20 vision. Another less common vision problem causes a loss in the ability to see to the sides and up and down. This condition is commonly called tunnel vision. The majority of students with visual impairment have varying degrees of useful vision. These students are often termed as being partially sighted. Unless someone told you, you usually couldn't tell the difference between a student with a mild visual impairment from the rest of the students who ride your bus. Other students have more severe visual impairments. Some may not be able to perceive light from dark. These students are referred to as being blind and may use a long white cane or human guide or a guide dog to get to and from your bus. Visually impaired students are within the same range of intelligence as other students. They're within the same range of hearing as other students. Have the same range of behaviors as other students. They want to do for themselves as much as possible. And they may need assistance where fully sighted students will not. As a bus driver of a visually impaired student, do the following. Have the same high expectations for behavior as for other students. If needed, find a way, such as a brightly colored poster in the window, to help the student with partial sight to identify your bus. Learn and use the student's name so the student knows who you're talking to. Offer wanted or needed help. Ask, "Can I help you?" Contact the orientation and mobility specialist who teaches blind and visually impaired students how to travel independently. Stop the bus at the same spot each day for students who are blind. Assist students who are blind by being a human guide. Have the student grasp your arm above your elbow or have a young child hold your hand. Encourage a blind student to explore the inside and outside of your bus when it's empty if the student has not had the opportunity to learn about buses through experience. Give the blind student the choice of an assigned seat. Use common sense. Keep your bus free of hazards for all students. Remember that these are kids first. Don't let your interests and efforts in dealing with their condition become the focus. It's important to treat each student as an individual with individual needs in a manner appropriate to each student's age. As you've already learned, your attitudes are very important. Be positive and encouraging with all students. Take the time to learn all you can about all students on your bus. It's essential that you communicate with teachers and parents about the students who provide a challenge for you. Allow each student as much independence as you can safely afford. They need the freedom and opportunity to make choices so that they develop an independent attitude while learning to be safe on the bus. Plan ahead for emergency situations. Remain in control of your emotional reactions and the situation at all times. You are the adult, the one in charge. Keep parents and school officials informed about good days and behavior and any special or unusual problems you may be having. Tell them the facts with very specific examples. Always remember that people like to hear good things as well as problems and concerns. Learn the language of the students on your bus. Communication is often a major problem. If you learn how to communicate with the student, you'll be more successful. Use the 10 R's for managing the students on your bus. If you need help with this, speak with school staff. Have positive expectations of students on your bus, but be realistic. Provide assistance only when necessary. Encourage students, give them positive feedback, but be firm, fair, and consistent at all times. And remember that students' abilities, interests, motivation, behaviors, and attitudes will change day to day, and sometimes minute to minute.